I'm going to talk to you about acute ischemic stroke. I'm going to talk to you about acute ischemic stroke and some new therapeutical strategies to improve outcome. My declarations of interest are just that all of my research is in precision medicine, and I have a big bias and belief in personalized targets and care. So a little bit I thought was interesting about IV thrombolysis. So I don't know if I'm old or young now, but it's an exciting time for stroke. Things are changing very rapidly, even within my career, my lifetime. Originally the thrombolysis originated in myocardial infarction, looking at streptokinase. It was first used by a brave individual in 1958. Subsequently had very mixed results in trials, and finally actually a very good randomized controlled trial done by a group in Italy really solidified that thrombolysis was beneficial for myocardial infarction and led to a very fixed protocol and dissemination. 1 year later, after that trial, alteplase was first approved for use in the US, and then 6 years later, there was a very good randomized controlled trial published in New England Journal, and alteplase became preferred thrombolytic. There was a lot of internal bleeding with streptokinase and better risk profile with alteplase. Then only a couple years later, the National Institute of Health in the United States did a trial looking at alteplase in acute ischemic stroke and found benefit. So this was a diffusion of innovation. This was around the time I graduated from college, so I wasn't even aware of this. I went to my stroke fellowship, and it had only been about a decade since TPA or alteplase was available, and even there, almost a decade after, the diffusion of innovation was very, very low. And a lot of the research at the time was on processes of care. Why can't people seem to get alteplase into the body? Well, if you've ever tried to give alteplase, it's quite complicated. It's stirred, not shaken, a little bolus given, calculation by body weight, and then given over an hour. So it was FDA approved in 1996 and quickly followed in multiple countries and then across Europe by 2002. But since then, a lot of research has gone into whether tenecteplase can be a replacement for alteplase. So the advantage of tenecteplase is more specific. It works probably better. It's more specific for fibrin, has a longer half-life. The one con being that you don't have an hour to change your mind. So if something bad happens, you can't stop it. It goes in over 5 seconds. It's a single bolus. So around 2010, it was the first trial of tenecteplase, and actually was prematurely terminated because of very slow enrollment. People were really stuck on. It was around this time where IA therapy was being rigorously studied, a lot of failed trials, some questionable trials that were promising. And then several trials after that showed this benefit, but really before endovascular therapy, which I'll call EVT. So Extend IAT&K, which was published in 2018, was a very definitive trial that showed prior to endovascular therapy, tenecteplase was superior to alteplase. So that's 2018. So this reached the guidelines of the European Stroke Organization in 2022. They decided to promote 2 thrombolytics. One for if you know the patient has a large vessel occlusion, tenecteplase should be given. If the patient is not eligible because they don't, for endovascular therapy, you can stick with your alteplase therapy. But since then, since 2021, several things have happened. So these 2 middle ones, the ACT and the TRACE-2 trial, are 2 randomized controlled trials that showed, tenecteplase is non-inferior to alteplase, and you have this big benefit, like I mentioned, about a fast administration. And in the era now where thrombectomy is an option, a lot of times you drip and ship. So you give TPA or you give thrombolysis, and then you transfer to a center that can do endovascular therapy. So that time is really important if you can accomplish your thrombolysis and then send away for thrombectomy. It saves your door to needle. And so this interesting prospective observational cohort study was published in last year that actually showed effectively that in a registry across Texas of multiple hospitals, and this is a practical trial, you could reduce the door to needle, so door to thrombolysis, and door to door, meaning door to transfer. You could also mildly reduce you can increase the favorable outcome and also the cost per care. It was also shown that in mobile stroke units in Melbourne, that tenecteplase is more efficacious than alteplase. And this was demonstrated by perfusion mismatches once we reached the hospital. So it was a smaller mismatch upon arrival to the hospital. So then in 2023, the ESO released an expedited recommendation updating this new data that had been published within the 2 years since their updated guidelines. So now you can say that acute ischemic stroke we generally think of as being treated if you have symptom recognition within 4.5 hours of the last time you were known well. So that 4.5 hour window is really important. So in that, it's non-inferior to tenecteplase. It could be safe and effective as an alternative. If you're giving it in a mobile stroke unit, it's better. It's better than alteplase. If you have a large vessel occlusion, it's better than alteplase. The one caveat here is there's this one area of acute ischemic stroke for thrombolysis, which is after 4.5 hours. So many patients will wake up with the stroke. You don't really know when the onset was. It could have been at the very moment they went to sleep or right before they woke up. And so it could be 0 hours, or it could be whatever time it was that they were sleeping. So this is termed a wake-up stroke. So there were guidelines, not so much guidelines, but selective recommendations that you could give alteplase for that thing. But the TWIST trial, which was published this year in the Lancet Neurology, compared tenecteplase with no thrombolysis for this acute ischemic stroke after the 4.5 hour window, and showed no change, no benefit, which is surprising. As opposed to the wake-up trial, which we are more familiar with from 2018, that looked at alteplase for this wake-up stroke, but using imaging for trying to phenotype your patient. So if a patient comes in, they've woken up with a stroke, you don't know, or an unknown time of onset, you do an MRI, and you see a diffusion lesion which shows acute ischemia, but it hasn't been established on the flare, on the T2 signal yet. There's actually no upper limit of time. You should give the alteplase. If you have a perfusion scan, you can look at these quantitative measures of your mismatch ratio, your mismatch volume, and whether your core volume is small enough. And you could consider alteplase. So again, this is confusing, so I'm just going to say it one more time. So acute ischemic stroke, less than 4.5 hours, tenecteplase is either non-inferior or better, but not for the wake-up stroke. You can still consider alteplase. So I'm going to talk a quick review, because I don't think it's all neurologists in here, about large vessel occlusions, or LVOs is what you'll hear about. So the large vessel occlusions, I apologize because I don't think I noticed this, but can you see the higher A1 is actually supposed to be A2. That's A2. So these are the distributions of your vascular territories of stroke. The large vessel are the anterior cerebral artery, or the A. The 1 means the most proximal portion, and A2, which is mislabeled, is the more distal portion. M1, M2 is the middle cerebral artery. It's just sort of where it is in the front, middle, or back of the brain. And then the M1 is the proximal portion, and the M2, there are branches that are a little bit more distal. IC is internal carotid. It feeds into the middle cerebral artery and the anterior cerebral artery. And then you have the posterior circulation. That's the basilar artery, which is a single artery, and feeding that are 2 paired vertebral arteries, right? So if you come in within 6 hours, you can go for any one of these large vessels. You'll notice the posterior circulation, posterior cerebral artery is missing here. It is a large vessel, but it was not included in any of these thrombectomy trials. So there's no guidelines saying this. There are people who will approach removal of the PCA occlusions. If you come in up to 24 hours, you're eligible for thrombectomy consideration. But if you come after 6 hours, really the studies have really only shown the ones that are rimmed in red. So the proximal MCA, proximal middle cerebral artery, and the intracranial arteries, and then the posterior circulation. Okay, that's the quick visual review. So you come in within 24 hours of your last known well, and you've been given your IV thrombolytics if you are eligible. We talked about that. Now you think about, can we do mechanical thrombectomy? So there are some thresholds here. Your NIH stroke scale, right? It should be worth it. You should be disabled enough that it's worth the risk of the mechanical thrombectomy. So that generally is an NIH stroke scale or 6 or above. However, it could be lower if you have a very severe disabling lesion like aphasia. Or if you're a violin player and that's what you live for, and you have hand weakness. So these are some considerations for individual people. So upon making that decision, you look at something called the aspect score. This was derived in Alberta. That's what the A is for. And basically, you look at the CT. There's a total of 10 points on one hemisphere. So you'll see this caudate nucleus is the C, internal capsule is the IC, the lentiform nucleus is the L, the insular ribbon is the I, and then you have the anterior middle, and then you have the posterior middle, and then one level above that, you have the anterior, middle, and posterior. So those are 10 on one side. If you count down, you look at the CT scan, you see what parts are at the time of entry, what parts are affected by the stroke. Now, if you have more than 4 of those areas, that is considered to be too large for this approach that I'm showing you on this slide. Okay? So that's an aspect score of 6 or above. It's good enough to go for thrombectomy. Now, if you come in that first 6 hours, you can go for all of the vessels. If you come in after 6 hours, you can go for the proximal ones. Plus, you need to prove that it's going to be benefit by looking at a scan. So if you come in 6 hours, all you need is the non-contrast CT and an occlusion, the CTA, or something demonstrating an occlusion. You go straight to angiogram. If you have, these are the 2 big trials that sort of determined how you determine if you can go after that 6-hour period. You can look at a clinical versus an imaging mismatch. So your NIH stroke scale has to be X, and your infarct has to be small enough, has to be mismatched. Or by the diffuse 3 trial, you have a perfusion scan. You can look at the mismatch ratio and the core infarct. You can look at the perfusion mismatch there. There are, exclusion criteria. I'll let you guys look at that at the point of care, to exclude people who've had surgery in the last 3 months, et cetera, things like that. In thrombectomy, the exclusions are really like platelets that are really low, INR that's really high, you have really severely tortuous vessels, just can't get in there. You have a severe allergy to contrast, something other than just a rash or hives. Your life expectancy is less than 6 months, your pre-stroke disability is high, or if you have an intracranial hemorrhage. These are, contraindications to doing thrombectomy. What about the posterior circulation? Because that basilar is one unpaired structure, it's a lot of real estate. It's sort of the stem of the bouquet of flowers. So if you have a lesion there, it's a very devastating stroke. And so the way the posterior circulation aspect scores is, again, it's 10 points, but it's both sides you consider, right? So you look at the occipital lobe, 1 point each for side, cerebellum, 1 point each. You have the thalamus, 1 point each. Then your midbrain and your pons, which are 2 levels of your brainstem. If you have a lesion anywhere in there, you get 2 points for each, right? So your aspect score here has to be 6 or greater, again, to really think it's worthwhile to do a thrombectomy. You're going to derive any benefit. Again, you shouldn't skip thrombolysis if you are eligible. And there's this other consideration called the pons midbrain index. So because that real estate in the middle is so important, you break it down into 8 parts. So if you have any more than 2 of those parts, so if you have half the pons, you're okay. If you have half the pons and part of the midbrain, it's probably not of benefit. Your clinical situation is probably too dire. So I've said all this about your aspect score. You have to be good. You have to have a mismatch. Then throwing into the loop is this year there were multiple trials that changed this. This is a dramatic change. This is really probably changes the practice of INR in the hospitals and your neurointensivists and your neuro INR colleagues that you know. So thrombectomy after a large ischemic core was always thought to be, well, it's not going to be a benefit. So the Angel Aspect score and the Angel Aspect trial and the Select 2 trial actually show that for your aspect score of 3 to 5, or an infarct that's quite large, greater than 50, greater than 70, if you can approach within 24 hours, it demonstrated that thrombectomy, while having some symptomatic hemorrhage, derives functional outcome benefit in 3 months. The Japan trial was also published this year in stroke, and I think it was published in stroke, and maybe it was not as impactful because it was only in the first 6 hours, but it's still very important. Interestingly, the last trial here, Tesla, which was in Central Texas, it showed that the endpoints were not met. But there were no safety concerns. And taken as a whole, given these 3 positive trials, especially the 2 middle ones, this is probably practice changing. And so right now, at least in my center, we are changing our protocols to include thrombectomy for large ischemic core strokes. The questions that remain, especially because the Tesla trial was not positive. Oh, and the Tesla trial was based just on CT, so not on perfusion. So if your CT scan met this aspect criteria, you just went. Is non-contrast CT sufficient to triage patients? That would change our therapy. It would reduce radiation. It would reduce time to treatment. And then is there an infarct size that's actually too big to treat with EBT? Because at this point, everybody should go, right? If you come in within 24 hours, you should just go. Why not? So it's interesting how far the pendulum has swung from when I was in stroke fellowship. People were up on their feet arguing against mechanical thrombectomy. And it was difficult to enroll in trials because the people who believed in it truly believed in it because of the physiological likelihood that this was going to work and the lack of the randomized controlled trials on the other side. Seems familiar. That's like a lot of medicine. So if you were to protocolize this, you would again screen for pre-stroke, modify Rankin less than 2, so you have no disability prior to, if you have a very low aspect score. The additional exclusions that we are using for this, because it was in the trial, was if you have midline shift, if you have bilateral strokes, and if you have multiple occlusions. Those are probably exclusions, even if you're within 24 hours. And then finally, hemodynamic management. So this is a trend in stroke, too much, too little, what's the right one? We do these randomized controlled trials, and we have to draw with large brush strokes. But several interesting trials came out last year and this year. So the Enchanted 2 MT trial was published last year in Lancet. And this was in multiple countries. This was like China, Australia, the UK, and across Europe, like Amsterdam, and a couple other countries. And this was comparing, okay, you've done the endovascular therapy, you've taken out the clot, what should your blood pressure be? So some people think you should have a very tight blood pressure control because you don't want to have a reperfusion injury and then hemorrhage. And others think, well, what is the proof for that? Let's just do routine care, keep it below 180, which is what we do after IV thrombolysis. So this study compared systolic blood pressure less than 120 versus your normal care of 140 to 180. And it showed that your MRS was far worse with a very strict low blood pressure goal. Interesting. The second trial that was done was published this year in JAMA, Optimal BP. This was performed in South Korea in multiple hospitals. And this one compared less than 140 versus 140 to 180. And this was stopped early because of harm. And it showed that the patients with stricter blood pressure less 140 did worse in their functional outcome. They were fewer to reach functional independence in 3 months. The third one, BEST 2, is a US trial, multiple centers. And this one tried to look at 140, less than 160, and less than 180. And unfortunately, it was very well done, but unfortunately did not meet the pre-specified thresholds for reaching significance. But it showed that there's probably no benefit to less than 140 or 160. So this is all sort of throwing it all for the loop. So I think it definitively says this one, Crisis 1, is still ongoing, but I think we're not really, unless it shows that there is no difference, that would be very surprising, right?
Soojin, we have 1 minute left.
Oh, thanks. And then the HOPE trial is also still ongoing. This one's interesting. This goes towards a little bit more individualized therapy. So if you have a completely reperfused vessel after treatment versus a partially reperfused vessel, should there be a difference in the systolic blood pressure goal? We don't know yet versus standard operating procedure. So again, my bias and my belief is that it's probably a personalized blood pressure goals. How we derive this is really under investigation. Lots of groups are really looking at this. But for now, we must go with a randomized controlled trial. But I believe for hemodynamic management, the door is now open to try to avoid the lower blood pressures. Summary is that tenecteplase is good across the board, except for wake-up stroke. Wake-up stroke, you should still consider alteplase when it seems appropriate. Thrombectomy for even large ischemic cores, up to 24 hours is showing promise. And in general, blood pressure reduction after thrombectomy is probably harmful. That's it.
Thank you very much for that great talk. We have time for one or two questions. Can I ask the audience who has access to tenecteplase? Show me your hands. So the minority. This is also what is that also your experience in US?
Yeah, well, our hospital is sort of across the board. I mean, our hospital hasn't officially gone over to tenecteplase. We're going over officially in January, because I think it's still on the FDA docket. So.
One short question. We are getting more and more aggressive in thrombectomy. You were talking about the large hemispheric stroke, but it's important also to mention the small ischemic stroke with a substantial deficit like aphasia, M2 occlusion. What is your recommendation on these patients?
It's personalized, discussing with a shared decision making with families, understanding the patient preference. I think if you have aphasia but your NIH stroke scale is less than 6, we'll go for it. That's also a general trend we see in different units, that we actually we treat these minor strokes more aggressively, and I think that's coming more and more in the field. Okay, thank you very much for that talk.